The paradox of empathy. I'm an ICU doctor, and in this Substack article that I wrote last year, I'm going to do a live rendition of it, describing how it feels to resuscitate thousands of patients. The paradox of empathy. Does detachment foster increased empathy? These are hard lessons from a doctor. ICU shift, hour 18. I stand at the edge of the bed, running a code blue. The patient is in cardiac arrest. In front of me lies a 45-year-old woman whose chest rattles violently with each chest compression. Her groin is bleeding. The bed is soaked with her urine. She appears lifeless. I'm surrounded by beeps, alarms, and the anxious chatter of the nurses and more than 10 people who are watching intently. I look at the monitors, and at our next pulse check, I declare that she remains in PEA, pulseless electrical activity. We continue our ACLS algorithm and administer drugs as indicated. I think through all the potential reversible causes and order the appropriate treatments. She was just in for surgery and subsequently suffered a heart attack. She had gone to get stents placed in her coronary arteries, and just 15 minutes prior to the code, she was communicating fully with the team. Around me, the nurses appeared stressed, panicked, and are awaiting the next order. Staring directly at the ugly face of death, one thought haunts me. Why do I not feel anything for her? I felt nothing. No sadness, no anger, no disappointment, nothing. I ask myself, is this normal? I started to have such thoughts a few years back during COVID, where the sheer number of deaths I witnessed per day were too much to process. At some point, I must have fully disconnected from feeling for the patient at a personal level. Does this make me a bad doctor? Or does it actually make me a better doctor? To answer this, I need to explain what I was like during the start of my medical journey. Through my journey as a doctor, I have found that my empathy levels towards my patients have fluctuated. As disturbing as that may be for some people to hear that, especially if they've been a patient before, it is the unfortunate reality. Many are familiar with the stereotype of the old cynical doctor, one who has seen too much death and suffering and is rough around the edges and too short with his patients. Maybe it's a coping mechanism after years of moral injury and feeling helpless in a system not designed to prioritize patient well-being. But there is also something deeper. When I started medical school, and especially started my clinical rotations in third year, I felt I had the highest levels of empathy. Many other medical students will likely cite the same. Why? Because I felt for my patients deeply. I connected with each patient on a very personal level and felt the emotions they were feeling, which usually range from sadness, anger, disappointment, confusion, relief, and many others, sometimes a mix of all of them. And let me tell you the first patient I was truly responsible for during my first month of third year medical school. The rotation was internal medicine, which is a specialty I was most interested in pursuing for residency. During the 4-week rotation, we were scheduled for 7 overnight shifts, usually one Friday and Sunday weekend, and another Saturday at a minimum, with some additional weekday call nights as well. At my program, you would work the normal day shifts, 7 a.m. to 5 p.m., and then overnight call from 5 p.m. to 7 a.m. But most residents would stay until noon the following day to complete seeing their patients, their notes, and follow up on urgent things. I was on the Friday-Sunday night call at the end of the first week. It's Friday night, and the senior resident gives me a patient to see in the ER, a 50-year-old woman who presented with leg pain and swelling. I spent about 3 hours with her. She was extremely rude and brash. Her son came halfway through my interview. The first half of the interview was like pulling teeth. She did not answer any of my questions clearly, just simple nods or hmms. When the 6'8" son came in, probably around 300 pounds, had a towering presence, he explained that she had not seen a doctor in over 20 years and she doesn't trust them at all. And then she adds to what he said, that all doctors are quacks. Being a bright-eyed, hopeful medical student, I thought to myself, I will do whatever I can to gain her trust and make her believe in doctors again. I leaned in. I explored her rough edges with curiosity and genuine compassion. Inevitably, she opened up a little bit more and even smiled at one of my jokes. This was a proud moment for me. For I felt that I had actually gone through to her. She told me her leg pain and swelling was getting worse over the last 1 month. The son told me that all she does is lay in her lazy boy reclining chair with her feet up and watches TV at an obnoxiously loud volume. She retorts back, "You guys are too loud in the house and I can't hear anything." I sensed the love and care between them through their banter. I almost felt like I was a part of it. Medically, I was worried that she had a blood clot in her legs, a DVT, deep vein thrombosis. So I told her we will likely admit her to the hospital for a couple days while we get a leg ultrasound and make sure to rule out a blood clot in her lungs as well. She has basically been immobile for over a month, a classic risk factor for DVT. So my suspicions were high. I reviewed with my senior resident and she agreed with the plan. I went back to the patient and her son to explain the plan for her admission. She just nodded and the son said thank you. I went on with my call shift, seeing other patients. I rounded on her again on Sunday and saw that the ultrasound was done but not reported yet. I updated her again and said that by Monday we will have an answer. Meanwhile, we had empirically started her on treatment already. I was post-call on Monday, so I came back to work Tuesday morning. By this time, she was already diagnosed with a DVT. On my morning exam, she was noticeably more jaundiced though, had elevated liver enzymes, and was complaining of abdominal pain and nausea. She was already awaiting a CT chest, so we decided to image the abdomen as well. The CT results showed she had metastatic pancreatic cancer, with massive pancreatic head mass causing obstruction of the common bile duct. I was devastated. No one had predicted this, not me, not the senior resident, nor the attending doctor, and definitely not the patient. When I reviewed with the attending doctor, she asked if I felt comfortable breaking the news to her since I had the best rapport with her. I agreed without hesitation. I felt it was my duty. Later that afternoon, I go to her room and sat with her for more than an hour as I explained everything that happened. She did not say anything, not a single word. I asked many times if she understood what this means, including that she may not have much longer to live. She would only nod. I left after holding her hand, giving her water, and telling her I will update her son too. I reassured her numerous times that I will do everything in my power to help her. I called all the different specialties to see what they could offer. General surgery, but they said the cancer is too advanced for surgery. Gastroenterology, who said they could insert a stent in the bile duct to help relieve some symptoms, but it won't change her prognosis. And oncology, who offered radiation treatment for symptom relief, but no chemo given the advanced stage. All of them came and saw the patient, some on Tuesday, some on Wednesday, but all mentioned in their note that the patient did not really talk to them. I went back after each specialist who assessed her and explained the plan in detail, asking her what she wants to do. She reluctantly agreed to get the stent placed to relieve her biliary obstruction, which helped with her abdominal pain and nausea for a while. The next 3 days were heartbreaking. She started to lose weight, became increasingly yellow and cachectic. She also started to become more confused. Friday afternoon, I again sat with her in the evening after my night shift was over to hold her hand and make sure she understood everything that was happening, and I tried my best to make her feel better. The son thanked me for all the time that I had spent throughout the week with her. He tells me she won't admit this out loud, but she has been thankful for you. She trusts you and listens to you, so thank you. And as I was leaving the room that afternoon, she muttered, "Thank you." Tears rolled down my eye as I quickly turned away from the room. I went home that night and felt the most helpless I've ever felt in my whole life. I sat alone on my couch crying. I looked up all the research I could on pancreatic cancers, trying to find something that could save her. I did not want to lose her. She finally had trusted me, and I let her down. She was going to die in front of my eyes, and I could do nothing. I was on call Saturday night again. I assessed her during morning rounds and saw that she was now actively dying. The son was considering implementing palliative measures so that she can pass in comfort. He asked me if he should do that, despite 3 different attending doctors telling him that it's the best next course of action. He trusted me, just like his mother. And with a heavy heart, I said, yes, I do not think she would want to suffer in pain in her last moments. He nodded in agreement and told the nurse to start comfort measures. I was quickly called away to see other patients that I had to round on, and new consults in the ER. I could not stop thinking about her. To be frank, I do not even remember any of the other patients I saw. As I was leaving home post-call on Sunday around 12 p.m., I stopped by her room and she was essentially comatose at this point. I spoke with the son and I said, "Here is my number. Please call me when she passes. I want to be there." He nodded. The 18-hour call shift did not yield much rest. So I came home around 12:30 p.m. and passed out. I get a call at 3 p.m. from the son. I immediately rushed back into the hospital. I arrived at the bedside even before the in-hospital resident could come. I go inside the room, see her laying in her bed, lifeless. The son and I come out of the room. The 300-pound, 6'8" son leans onto my shoulders and starts crying uncontrollably, almost losing control of his body. I hold him, while I also could not help but cry. The stubborn and brash woman who I gave everything to gain her trust was now gone, just like that. Her personality, her quirks, her banter, her humps, all gone. The resident came and pronounced her time of death. I told the son to please contact me if he needs anything, or if there are any questions or concerns that come up regarding anything. He was gracious, and he gave me the biggest hug. I came back home and cried myself to sleep. I could not stop crying later that night when I woke up from my nap. The next morning, I was supposed to be back at work. I had over 2 weeks left of my first ever inpatient block of rotations. I showed up late to work the next morning, as well as multiple mornings the following 2 weeks. I was depressed. I had no urge to go to work, nor care for any patient. I thought to myself, what's the point if my patients will die anyway? What power do I even have to change things? It was a dark period. I'm grateful for the attending doctor who was on that last week. She was a recent graduate and the most kindest human. She noticed a change in my behavior and functioning from the first week to the last week and took me aside to her office. We had a long chat where I explained everything. She provided much needed mentorship and reassurance. She provided me with the perspective and hope I needed. She treated my vulnerability with care and gentleness. For that, I am forever indebted to her, because I do not know how deep I would have spiraled in my depression had no one checked in. And all my friends and family were in a different city, and how could I explain to them the depth of this experience? She made me realize that losing patients is an inevitable part of the doctor journey. But what's more important is that we do the absolute best we can for each of our patients. If we do the best we can, advocate as much as possible, and yet the patient has a bad outcome, we really cannot hold ourselves responsible. But because what about the next patient and the next 100 patients? Who will care for them if we sulk in our pain of losing one patient? Who will give them just as much care and attention? Are they not deserving of such level of care too? I spent some time thinking about what she said, meditating on the loss I experienced, talking with friends and family, and I finally found some strength to move forward. But from that point on, I built a certain internal wall that would limit me from connecting to patients at such a deep personal level. In fact, all health workers do this. It is a byproduct of our jobs. We need to connect enough to understand our patients, but if we connect too deeply and our patients suffer a bad outcome, then it leaves us devastated and incapable of helping the next patient. Those patients I saw in the last 2 weeks of the rotation, I don't even remember them. Did I give them good care? I don't know. And that's the issue. While I felt immense empathy for this one patient I had connected to, I neglected my duty towards the other patients. Is that not unfair? As I progressed through my medical career, there have been many cases that have touched my heart. No matter how high you put your walls up, we are only human. But ultimately, most doctors build their own internal balance between connecting with their patients and keeping a certain emotional detachment. This exists on a spectrum, and some doctors go too far towards the detachment side after their experiences, which ultimately is just a form of self-preservation. Circling back to the initial Code Blue situation, if I really felt deep empathy for the patient, for the dying 45-year-old woman, I may be too emotional to think thoroughly through all the potential reversible causes of her cardiac arrest. In that moment, it was in fact best for the patient that I was fully detached, devoid of emotion. I was only focused on finding the cause of the arrest, managing the chaotic room full of people, and bringing her back. In that moment, emotion and empathy would have hindered my cognitive ability. One may apply a similar logic to surgeons who face unpredictable challenges during surgery, where emotional attachment may actually limit their ability to perform to the best of their surgical capabilities. Am I advocating for not caring for our patients? Absolutely not. However, it is crucial to develop our own balance of connection versus detachment towards our patients, one that feels right for you. And regardless of how detached you are, it still remains our duty as physicians to do everything in our power to care for our patients. I can advocate for my patients without necessarily feeling the same emotions they are feeling or outwardly showing my empathy. If I get my crying patient a tissue box, which showcases empathy, but I do not go and make the difficult call to the insurance company afterwards to fight for her, what use is that empathy? Hence, a certain level of detachment is necessary. While other situations, such as discussing end of life or withdrawal of life support with patients' families, require higher display of empathy and presence from our part. I would highly encourage more healthcare workers to examine how high their psychological walls are, and would kindly suggest softening them to reconnect with the humanity of our patients. Because while detachment may make us more efficient in our jobs, being present for the patients and being someone they can trust and rely on is just as much, if not more, important. Especially with AI demonstrating that it can and will replace many of our cognitive abilities. Our ability of being human, building trust with our patients, and advocating for them will emerge as our core functionality as doctors in the age of AI. Even as I write this now, I cannot help but cry uncontrollably. She was my first patient, and I will forever remember her. This post is in her honor. She taught me what it means to be a doctor and how much privilege we carry as doctors. Our privilege is that people in their most vulnerable states trust us. They believe in us to listen to them and do what's best for them. We would do well as a profession to honor this trust and remind ourselves that it can be lost more quickly than it can be built. Thank you.